Thank you very much for joining us today. My name is Kara Endike-Doran. I'm the team lead for the Women, Children, and Adolescent Health team here at MSH, and I'm going to be moderating this session. First, we'll have a presentation for about 35 to 40 minutes, followed by a series of questions and answers. If you have any questions throughout the course of the presentation, please write your questions in the chat. Today we'll be sharing lessons learned from our Group ANC implementation research. MSH, with our partner Scope, implemented Group ANC, or pregnancy clubs as we have begun to call them, as a strategy to address the growing body of evidence which shows many women in low and middle income countries are not getting the respectful, supportive, high quality antenatal care that they need and expect. Next slide. So this is actually the fourth webinar in our Quality of Care series, which is titled Quality of Care, an Essential Pillar to Achieve Universal Health Coverage for Women, Children, and Adolescents. Through these webinars, we have hoped to articulate the ways in which MSH has addressed quality for women, children, and adolescents in different contexts. We have tried to share our results and lessons learned, but mostly we want to continue the discussion around quality and talk about strengthening quality of care initiatives for more effective and efficient health systems. Here at MSH, we believe that health systems must respond and adapt to a person's unique health needs as whole people throughout their life course and within the context of their lives. We know women, children, and adolescents continue to die from preventable causes and face barriers to equitable, high-quality health care. And this is why the Women, Children, and Adolescent Health team at MSH has prioritized quality as a key pillar in all of our approaches. Next slide. We will be hearing from our colleagues in Kenya and in the United States to discuss the results of our implementation research. This presentation will be given by my colleagues Shafia Rashid, Kate Ramsey, and Priyam Sharda. Kate Ramsey is a maternal newborn health expert with nearly 20 years of experience. She holds her MPH from Columbia University Mailman School of Public Health and is working on her doctoral dissertation on disrespect and abuse in childbirth. Priyam is a design research lead for Scope, one of the partners in this study. Priyam holds her MSc in social anthropology from Oxford University. She worked on the Kenya and Guatemala projects, which we'll be hearing about today. She believes strongly that framing the right context and building incremental learning at every step in the design process is the definitive way of designing the right solution for complex problems. And Shafia is a principal technical advisor here at MSH with the FCI program. She supports advocacy and accountability projects on maternal health. She holds her master's in international affairs from Columbia University's School of International and Public Affairs. So I will now hand this over to Shafia to lead us through the presentation.
Great, Kara. Thanks for that introduction. Before we get started, can we move to the next slide? So before we get into the meat of the presentations, we wanted to begin by providing an overview of our approach and the findings from our research. There's growing interest in understanding how a group-based model for antenatal care can address both gaps in both coverage and content and provide women with greater responsiveness, quality, and support as part of a positive pregnancy experience. MSH and Scope, working closely with government and other partners in Kenya and Uganda, adapted the Group ANC model, which we call pregnancy clubs, to the local context using human-centered design and tested its feasibility and acceptability in selected public sector facilities. As you will hear in more detail later on in the presentation, our implementation research indicated that women had an enhanced experience of care, learning information to support a healthy pregnancy and newborn, and finding social support through the friendships they made with peers and their healthcare provider. We also found some indications of improved self-efficacy and empowerment, specifically among younger women, adolescents. Providers saw value in providing better quality of care and in developing relationships with women, but also struggled to integrate the approach within their daily routines. While we found that pregnancy clubs hold promise for better meeting the social support and informational needs of women and for improving the quality and coverage of ANC, further testing is needed to understand how to address the health system's barriers needed to take this innovation to scale, which is part of our current work in Guatemala. Next. We know that ANC provides a woman and her newborn with the opportunity to have a healthy pregnancy. It serves as a platform for delivering essential health services, supporting healthy behavior and practices, and linking women and communities with the health system. However, we also know that there are gaps, both in terms of coverage and content. While most women receive at least one ANC visit, many women do not come back for subsequent visits. Essential components of clinical testing and screening are often missed, for example, for malaria prevention. More vulnerable populations intersected by age, education, socioeconomic status, and geography are less likely to have access to and use high-quality care. The quality of care that all women receive as part of ANC is often inconsistent. Services are generally not responsive to women's expressed needs, and providers are sometimes disrespectful. There are also a range of systems-related challenges, such as lack of essential supplies and medicines, inadequate privacy, and lack of infrastructure that contribute to less than optimal use of ANC. Next slide, please. Group ANC models promoting self-care and social support are emerging as a promising alternative to address some of these gaps in ensuring high-quality ANC. This new model is aligned with recent recommendations from the WHO to develop integrated, responsive, and people-centered health services that address both the provision of care, the clinical components that we are all familiar with, and respond to what women want from their pregnancy experience, taking into account needs and expectations across different contexts. As part of Group ANC, women meet with the same health provider over the course of their pregnancy. Through facilitated discussions, women learn essential health information and share personal experiences. They also participate in taking their own basic health measurements, such as weight and blood pressure. Meta-analyses show similar health outcomes between group and traditional care. Published studies do show positive associations between group care and birth preparedness, knowledge of danger signs, and uptake of family planning. Women leave group care with more knowledge and confidence, and they gain social support from their peers. Group care models also have potential to improve health providers' motivation in some contexts, with providers reporting that they were able to provide better care and received a better professional experience through the group model. We know that measurement of some of these effects, such as empowerment and social support, are often challenging and have not typically been studied in low to middle income countries, especially in relation to ANC. Next slide. MSH worked with Scope and local partners in Uganda, Kenya, and Guatemala to design and implement a contextualized group ANC model. We used human-centered design to address and incorporate women's and providers' views and perspectives. We then rolled out group ANC in public sector facilities. We conducted implementation research to understand the what, why, and how interventions work within real-life settings. And we began to identify pathways to scale. What are the systems requirements, including human resources, infrastructure, financing, and policy? In Uganda, MSH worked with the district health team to conduct a feasibility study in 6 health facilities in 2 districts in eastern Uganda. 2 midwives per facility were trained in facilitating pregnancy clubs. 22 groups with approximately 8 to 12 women per group were established across the 6 sites. In Kenya, MSH, the Kenya Progressive Nurses Association, and the county health team supported a pilot study in 6 sites in Kakamega County in western Kenya. We took a whole site approach where all ANC service providers were trained through on-the-job training. The Nurse Association's supervisors provided peer mentorship and supportive supervision to ensure model fidelity. A total of 1,690 women were enrolled over the implementation period. And at the request of the Ministry of Health, we tested the feasibility of the WHO recommended 8-visit ANC model. In Guatemala, we are working with departmental health authorities and indigenous women and communities to design and implement pregnancy clubs in the Altiplano region, taking a phased implementation approach, a 6-month pilot followed by scale across 30 sites. Now I'll turn it over to Priyam Sharda from Scope. Over to you, Priyam.
Hi, thanks, Shafia. Next slide, please. I'll start to briefly talk about how Scope helped partner with MSH to create a service delivery model for these pregnancy clubs. But just to introduce Scope very briefly, we're based out of Helsinki, and we follow an interdisciplinary process that uses human-centered design as the base to design creative solutions for challenges such as antenatal care and just other complex challenges in the space of health and development. What you're looking at in front of you is something that most of you might be familiar with. It's the 4-step or the more classic 4-step human-centered design process that most firms follow. And I'll talk about it in the context of this project. The first step is discover, which means we typically conduct an exploration that gives us the answers we need in order to be able to effectively design a solution best suited to the context. For this project, it meant exploring existing qualitative literature. It meant speaking with our partners at MSH and understanding the challenge at hand. The little dotted lines that you see sort of traversing through the 4 beads in front of you, it represent the process in the sense that we're constantly seeking stimulus that expands how we look at an existing problem. And then the divergence of that is us finding ways to action the learning that we just sort of absorbed. In the case of Kenya, like I said, and in Guatemala, we would first do a qualitative understanding of the problem at hand. And then from what you can see as understand, which is the second circle onwards, we would work with partners in field to really help co-design and co-create solutions that work best with the key stakeholders on ground. Next slide, please. So creation in the context of this project meant really co-creating with key stakeholders that we had identified, which in this case ranged from community health management teams to care providers to mothers that were going to attend these pregnancy club sessions and even community members. Some of the pictures that you see in front of you are from the sessions in Uganda and Kenya, and we use methods that were sort of more time intensive that involved mock pregnancy club sessions to more focused discussions around what these materials need to be and how they can help address existing systemic challenges with, let's say, for example, to do with nurses' schedule management or just the sort of the physical distances that mothers have to traverse in order to make it to some of these pregnancy club sessions. What this often meant was to take tools and materials developed in one of the earlier geographies, Uganda in the case of Kenya and Uganda in the case of Guatemala, with making some initial minor adjustments to serve as a starting point to try and answer pretty early on what is it that works in this context and what doesn't, and how we can make it better and better suited to the context. Through these discussions and through these sort of sessions in field, we started to create appropriate materials and appropriate provider job aids in order to help facilitate the delivery of this model. Next slide, please. What you can see in front of you is the typical output from each of the geographies as part of the work that we did there. We would typically emerge with a group ANC Navigator, as we like to call it, which represents the entire service journey in its entirety. What we take into account are the needs of the provider, along with the needs of the mothers that are attending, and along with any sort of insight that we receive from the local health management teams and the local MSH teams. Some of the common characteristics across each of the countries were naming these clubs themselves. What you can see in front of you is Lea Mimba Club, which was the name for the group in Kenya. And we've recently closed out, creating a similar service journey suggestion for Guatemala, where the group name is in Spanish and it's more literally in English, a monthly meeting for pregnant mothers. Some of the other common characteristics I would like to point out is the grouping by gestational age, which was a common characteristic in Uganda and Kenya, where mothers of similar gestational age would attend these sessions together on a monthly basis. But that's again something that we've changed in Guatemala based on what we heard back from the local care providers. All of these service journeys also have an opening and a closing ritual in common, which helps lend a sense of opening and closure to the sessions themselves. In Kenya, one of the elements that got introduced quite organically was an opening song. We found that providers started to sing with the mothers to help generate an environment of friendliness and openness, and that's something that we instituted as part of the model. All of the countries use picture cards or sort of visual support to help share messages with mothers, and the shape and form of that has changed from one context to the other based on what providers thought was most useful to them. In Kenya, for example, the calendar was introduced, as you can see on that model, which is to help mothers keep track of when their next appointment is with the pregnancy club, but also in addition, it served as a community engagement tool that allowed them to take it back home, showcase it to their family members, and so on. And then one of the other common elements is that of self-check, which was again an interesting thing that we learned in Guatemala, where care providers weren't very sort of supportive of self-checkups in that context, but in Kenya it was encouraged very much. Next slide, please. Here are some pictures of some of the materials that I just mentioned. Typically, each of the locations have their own version of an ANC mat, which allows all the materials to be kept together, making it easy for the provider to utilize them. Like I said, the visual cards change in their sort of form in every country. Here, what you can see in front of you are the accordion scrolls that we used in Kenya. But in Guatemala, our latest suggestion has been to use round disc-like cards that have only one image right in the center in focus, as that's what the providers said they preferred. And the last image on this slide is that of a calendar booklet, which, as I've already mentioned, allows her to keep track and also allows her to keep track of her key messages. I'll hand over to Kate next.
Okay, thanks very much, Priyam. This is Kate Ramsey. I'm going to talk to you a little bit about what we found from our research in Kenya and Uganda, because we've just begun in Guatemala, but we have some important lessons we think we can share from our experience in Kenya and Uganda. As mentioned by Shafia, we implemented the model in 6 facilities each in Kenya and Uganda and conducted implementation research to document and examine the experience with Group A and C as well as effects. In Uganda, implementation was for a period of 5 months, followed by qualitative research to understand the experience of care and implementation among women and implementers. In Kenya, we implemented for approximately 1 year and followed retention of women enrolled in Group A and C longitudinally. Although more than 1,600 women were enrolled in pregnancy clubs in Kenya, we analyzed data from the 1,090 women among the cohort who would have delivered by the time of the assessment to ensure that they would have completed the full potential cycle. We also interviewed women at immunization visits at the study sites before and after the study and conducted qualitative research with women and implementers at Edline. Finally, to gain a sense of workflow and time use for the groups as compared to traditional ANC, we conducted observations of ANC before and after introduction of the pregnancy clubs. Next slide, please. Now, we analyzed each data set and triangulated findings to summarize our results in relation to the WHO framework for quality of maternal and newborn health care, which many of you will be familiar with. We focused on analyzing elements related to experience of care, which we hypothesized would be most influenced by this model, and less so the provision of care, particularly clinical aspects of care. And then we also looked at coverage of key practices, as well as some of the experiences of the providers. We know that this framework was originally designed with a focus on intrapartum care, but a recent Cochrane qualitative synthesis of antenatal care shows us that the experience of care categories are also likely quite relevant for ANC, although may need some nuance. Next slide, please. So I'm going to first start to talk to you about the experience of care. As part of the client pre and post surveys in Kenya, we asked about women's experience of care in a variety of ways because we know that there's a lot of variability and some unreliability in different ways of asking about experience. As you can see from the chart, all show a pattern of increase from baseline to end line. The first two indicators show that women's satisfaction increased and their likelihood of recommending the facility increased as well. And the satisfaction with ANC experience we've tested now statistically, and we found that this is a significant change from baseline to end line. If we look at the following 5 columns on the right, women were asked to rate these quality aspects from excellent to poor, with good scaled as neutral to account for any social courtesy bias. The ratings of different aspects of care show the same patterns of increase, with the largest change in ratings of provider competence, which we found interesting. We are still finalizing the statistical tests, and in the future should have more to report about whether these findings are significant as well. Next slide. Pregnancy Club member in Kenya told us about the respect and dignity she experienced. In the normal ANC clinics, you will find some nurses are tired and they will not attend you well. But in the Liamimba Club, the nurses do not discriminate against anyone. When you go to other clinics, you are told you are dirty. Here you are attended to the way you are. As we hear in this quote, the qualitative data showed that women experienced improved respectfulness of the provider, and importantly, many talked about a reduction in the experience of discrimination or perceived discrimination. They described how the midwives were friendly with them, although seemed to continue, as one woman said, harassing others who had come seeking care and hadn't formed relationships with them yet. So this may not have spread to other services. In Kenya, where we specifically sampled adolescents, they also reported being treated more respectfully and with less discrimination, an important finding given global knowledge about adolescents' experience of care. Next slide, please. A woman in Uganda explained about the communications. What I learned made me excited. At the health facility, they teach us pregnant mothers about life, health, and pregnancy. I learned that if you feel bad and have pains in the womb, you need to tell your mother-in-law or husband and quickly get to the health facility. Our qualitative data in both countries revealed that women were very pleased with the enhanced learning in the groups, as you hear from this quote, something that even multiparous and older women appreciated as different from previous pregnancies. The sessions were described as lively and engaging, and the sharing of experiences and materials helped to facilitate this, according to both women and providers. Women recalled most frequently their improved learning about nutrition, danger signs in pregnancy and delivery, and the need to prepare items and money for delivery. Some women in Kenya reported that it influenced them to take and not discard their iron folate tablets and to sleep under insecticide-treated nets. And a few women in Kenya said they used the materials in their learning to share information with male partners about their pregnancy needs, and that it seemed to improve their relationship and communication. Next slide, please. The clubs, when facilitated well, fostered bonds among the pregnant women and with the midwife. Women reported that these relationships helped to make them feel at ease and to reduce feelings of stress. As the quote you see here says, sometimes you are hurting out there, but when you come to your colleagues that you study with, you calm down and relax, because the midwives used to teach us about togetherness and love, and so we made friends. Midwives also observed that as women got to know each other, they would become more free and share more in the groups. Women would also sometimes contact each other and even help each other outside of the groups. For example, there were some reports of sharing transport to ANC and helping sick friends to get to the facility or buy medicine. In both countries, women talked about having at least one friend in the group, and that this partner was an important relationship that often continued beyond the group, even in cases when they were not so happy with the group dynamics or with the other members in the groups. From mentor observations and reports in Kenya, it appears that some groups had poor dynamics. Sometimes the groups just didn't gel, and providers were not always sure why. This is something that we will need to and would like to explore further, and perhaps team dynamics research might provide some insights. Next slide, please. We were also concerned about providers' experience, as Priyam talked about. We found that the benefits were not limited to women's experience, and as one ANC provider in Kenya described, we learn a lot from these groups in terms of how women perceive the services that I'm providing. They get used to you and to the facility, and they are free. If there is a concern, they can tell you, so it is also a way of getting feedback from them. As this provider explains, they did enjoy and value the exchange with women, which helped them to understand women's situations and provide better counseling about healthy practices. It provided an opportunity for a two-way communication as compared to traditional didactic education sessions. The organized content and materials also supported them to facilitate the groups and conduct counseling more easily. While they saw it as an improved model of care, they struggled to integrate the group sessions into their daily workflow. They had challenges remaining free for an hour, which was the approximate length of the group sessions, due to emergency cases and deliveries that might arise, especially at smaller sites where there were fewer healthcare providers. In the design in Kenya, we actually designed it so that appointments would be scheduled for the afternoons to mitigate these issues, which we observed in Uganda. But providers continue to schedule for mornings, and something we might need to consider moving forward as part of thinking about changing provider behavior.
Great, thanks, Kate. So our qualitative data show that the learning and the social support that women reported experiencing as part of the pregnancy clubs may have further enabled them to enact healthy behaviors and improved feelings of self-efficacy. Here you have an adolescent woman sharing her experience with the Kenya Lea Mimba pregnancy clubs. I never imagined I could take care of my pregnancy. I never saw myself taking care of my child and using family planning. I thought it was a lot of work, but after the Lea Mimba sessions, I can do all of these things. Adolescents specifically reported that they became more confident and empowered to take action to improve their health and well-being. Because first-time adolescent mothers often face stigma from getting pregnant outside of marriage, have limited access to information, and less likely to use formal ANC services, we found their participation in these pregnancy clubs led to changes in their ability to take action. We also heard from older women in Kenya that they did things differently in their current pregnancy as compared to previous pregnancies. For example, they set aside savings for their delivery, they bought clothes for the baby, they maintained good personal hygiene, and practiced healthy eating. Next slide. One of the effects that we assessed in our Kenya study was retention in ANC. This graph provides an overview of the pattern of retention in our project sites for both group ANC visits, which includes the individual booking and intake visit. These are the red bars. And for total visits, which include both group and individual visits, the blue shaded bars. In our sample, we tracked women attending group sessions as well as whether they came for an individual visit. Some women may have missed their scheduled group appointments because of family commitments. They may have forgotten their scheduled date and time as well as for other reasons. We found that 76% of women in our sample completed 4 or more ANC visits, group or individual. This seems to be an improvement from the DHS for Western Kenya at 51%. It's outlined in that yellow line here. Through our qualitative data, we heard from women about some of the challenges in attending ANC, which may explain the tapering off that we see in this graph. Women experienced often long wait times because other women in their group arrived late. Some noted that the sessions really ran too long, and sessions were not often held as scheduled. Distance, lack of money, or access to transport were other challenges for women to attend sessions. Some women reported feeling hungry and thirsty while waiting for their pregnancy club sessions or during the sessions, and also noted that they had expected incentives for attending ANC, perhaps due to an ongoing cash incentive program that was ongoing in the county. A few women expressed disappointment when the health provider that was facilitating their session had changed and was replaced by another, which indicates they had developed a bond and wished that relationship to continue. The short implementation period also limited our ability to really see the full effect of the model on ANC retention. We know that the project sites were working through some initial implementation challenges that could potentially resolve over time. Next slide. As part of our Kenya research, we conducted observations using provider and participant time diaries at baseline for traditional ANC and an end line for group ANC. Time diaries indicated that women attending group ANC spent substantially more time at the clinic than their traditional ANC counterparts. One component of the time spent was the substantial increase in receiving education, in discussion, and in connecting with other women and their healthcare provider. On average, women attending traditional ANC received approximately 6 minutes of counseling with providers, whereas women attending group ANC spent approximately 55 minutes in counseling, representing an 805% increase. We found that the time a provider spent with a single woman in traditional ANC was approximately 18 minutes, and the average time a provider spent for a group ANC session per woman was approximately 21 minutes, but with improved counseling being provided. While providers were spending additional time per woman, group ANC may ultimately be more efficient given the improved quality of counseling being provided. Women in both traditional and group ANC frequently face long wait times. However, this was exacerbated for women participating in pregnancy clubs because of the way the client flow was designed in the facilities. Upon arrival in group ANC, women often waited for the group ANC session to begin and then queued again for the clinical examination. Based on our experiences in Uganda, as well as from the human-centered design research, it was proposed to hold pregnancy club sessions in the afternoon when client load would be less, but time diaries show that pregnancy club members were arriving in the morning and often waiting until other members arrived and providers were available. Providers talked about staff shortages as a key challenge to implementing the model, but seemed not to be willing to shift established routines of providing clinical services in the morning. This time and workflow data were based on observations for one group session per facility. We understand that there may have been extraordinary circumstances in 2 of the health facilities during the period of data collection. For example, only one provider was on duty and had to deal with an emergency and a woman arriving for labor, which contributed to the increased wait time that we observed. Next slide, and I think it's over to Kate.
Thanks, Shafia. So just to wrap up some summary of these findings and some of the thoughts about moving forward. As you saw from what we presented, we did find across the countries that the pregnancy clubs offered many women an improved experience of care and even brought joy, something we observed when we went to these places. And this is not something we typically talk about or aim for, but seems to be something we might want to try for. Yet some women, and maybe perhaps a minority, still prefer to attend traditional one-on-one visits. So we need to think about whether we would continue to offer those. It's not yet clear why some group dynamics fostered relations while others just didn't seem to take off, and this was seen even at otherwise high-performing sites. So some more research on group dynamics and how to foster that in cases where it's not taking off could be helpful. Our findings also indicate that the observed improvements in practices, including what we saw in terms of retention in ANC and preparing for childbirth, we think are likely due to the combination of improved experience of care factors. But these relationships of these factors need further exploration, and we recommend that future research continues to assess how the groups bring about change, not just whether the change occurred, so that we don't continue to promote form without the function of the groups being maintained. Group ANC did have positive benefits, but these could not completely overcome barriers to care seeking, such as geographic distance, cost, and other unexpected events that rose in women's lives. These resulted in women sometimes not returning at all or missing group appointments, and other approaches are needed to address these issues. We don't have a silver bullet here, as we say. In the period of implementation, we also didn't observe improvements in early initiation of care, So also something that might have affected the retention patterns, for instance, for the later visits. And other approaches are likely needed here as well, although over time, as the groups became more popular, we might see a change. Implementation at scale poses challenges in a variety of ways. First, it requires a shift in providers' mindset about what it means to provide quality ANC. We observed in Uganda and Kenya, for example, that some providers immediately understood and fostered relationships in the groups, while others required more time and mentoring to change their approach and tended to focus only on the education. At scale, we would need to maintain not only the form of group ANC and the education, but the spirit of the approach to see, for instance, effects in perceived social support. Secondly, group ANC is very different from other services provided in reproductive and child health clinics and consequently can be disruptive to workflow. We need to weigh the disruption and the positive benefits and perhaps consider whether other primary care services such as immunization and well child visits could and should be redesigned. We may also need to explore other less disruptive models for ANC that will produce similar effects of social support and learning, especially where resources are extremely limited. All of these still need fleshing out, and we should not throw out group ANC, but we need to see how we can align it to the current workflow patterns in these clinics. Finally, and in that vein, the contexts where we worked in Kenya and Uganda were quite similar, and other settings may require adaptations or completely different designs to produce these outcomes. That is why we're excited about our newly launched work in Guatemala, where we can look at a very different context. Next slide, please. And so here you see photos of the human-centered design process in Guatemala, where we are just about to start implementation. There we will be further exploring questions that arose out of our experiences in Uganda and Kenya. We hope we will also continue to improve our understanding of what is core to this approach and what requires local adaptation to maintain effectiveness and be responsive to women's needs. Next slide, please. So we want to finish by offering our sincere thanks first to the women and health providers who gave their time, opinions, and insights for the studies, our studies teams and project staff in Kenya and Uganda, and I want to note that we have a number of our Kenya colleagues on the line, Melissa, Joseph, and Fred, who were all part of the work in Kenya, and partners including national ministries of health, district and county health management teams, and community health workers. We'd also like to thank the County Innovation Challenge Fund in Kenya, which provided funding for the work in Kenya, and the MSH board and leadership team, who also provided institutional funding for the work in Uganda and to supplement the study in Kenya. And now I'll hand it back to Kara to facilitate the question and answer session.
So thank you to Shafia, to Kate, to Priyam for sharing the information on the pregnancy clubs today. I just wanted to make sure we took the moment to share where you can find more information about the pregnancy clubs. We have more information on our website, and there's also a link to a technical brief which highlights some of the findings of our study. And again, thinking about the learnings of the group ANC really highlights the importance of not only the client, but the provider's experience in care, and that in order to improve health outcomes, we really should be paying attention to quality. Next slide. And once again, thank you for joining. Before I open it up to questions, I want to remind everyone that this is the 4th webinar in our Quality of Care series. During previous webinars, we focused on using person-centered approaches to adapt the directly observed therapy model in urban Afghanistan. We talked about institutionalizing quality through the National Accreditation Program in Rwanda, through the USAID-funded Rwanda Health System Strengthening Project. And we also talked about providing quality of care in fragile settings, sharing experiences from the USAID-funded Integrated Health Project in the Democratic Republic of the Congo. So now I will open it up to questions. If you have a question, please type it in the chat box, and I'll read them to presenters. We have a number of questions that have already come in, so I'll get started with what we have so far. So the first question that I see here is really around the logistics of some of the clubs, and I'll direct these to Shafia. Were the sessions done after hours or during work hours? And could you clarify work hours? And could you clarify the purpose of the pregnancy mat?
Great, thanks, Kara. The club sessions were held during the normal clinic operating hours. So as we mentioned, we had suggested that the sessions be held in the afternoon to allow for providers to really focus on supporting the facilitation of the clubs when most of the client load had cleared from the morning rush. But it seemed like from our observations as part of the timeline assessments, most of the clubs were still being held in the morning, and so there were some challenges with providers having to attend to their normal clinic duties as well as to attend to the facilitation of the clubs.
So in follow-up to that approach or that question, did you find that the facilities were able to staff the group ANC sessions with nurses who were already on shift, or did they have to bring in additional staff for the group ANC?
Most facilities were able to staff and schedule the pregnancy clubs based on their existing staffing schedule and staffing roster. We did hear from some of the sites that they did do some adaptations. For example, if there were limited staff on duty, they would call on staff that were off duty to come in and facilitate their assigned club session.
Great. Thank you, Shafia. There was
Kara, can I
a
just
question.
add something about the scheduling? This is Kate. I just wanted to mention, too, that we needed to think not just about the providers, but about women in terms of scheduling. And we found that some women in some contexts, for instance, in parts of Kenya, the afternoon actually was better for them. They had a lot of tasks in the morning, and being able to free themselves of their tasks before going later would be helpful to them. However, in other contexts, some parts of Uganda, the more rural areas of Uganda, we found that bus schedules were only at certain times of day. So if you scheduled in the afternoon, many women would have had to come in the morning anyway because their only transport was such. So this is really a very localized issue that we feel is best done through some sort of process at each site to figure out what will work to respond to both women and the provider in that context. Thanks.
Great. Thank you, Kate. There was a question that came in for Priyam, and she wondered if there were other considerations for the group formation beyond just gestational age. For example, did we consider grouping by age? And perhaps this could also be for you, Kate.
Why don't I start, and we'll see if Priyam can join us. I know she's having some technical difficulties. So from the very beginning, we wondered about grouping by age and whether younger women would prefer to have their own groups and they'd feel freer in those groups. In Uganda, in our design research, we found that actually younger women said, and all women said they wanted to be grouped together, that they enjoyed sharing the experiences. And some of our research showed that the younger women did enjoy sort of hearing about and having sort of that support from older women and understanding from the older women's experiences. So they benefited from hearing about that. However, we did hear, for instance, in Kenya, where we continued to keep the groups mixed by age for similar reasons, that younger women might be less likely to speak up in the groups. And they might feel less comfortable over time to even open up the way their other counterparts did. However, when we looked at sort of people speaking about feeling empowered from the groups, the youngest woman said the most. So we have to kind of think about this from a mixed perspective, but I do think it would be interesting to do that. However, you also want to make the scheduling for the provider as simple as possible. So if they have to account for both gestational age and client age, that may be even further challenging for them to do. So interesting to look at, I think, and maybe the first-time parents work that's been going on might have some insights for us on that.
Great, thanks, Kate. There were a number of questions that came in regarding how participants were recruited into the pregnancy clubs and how they were made aware that the pregnancy clubs existed. So could you let us know, how did we enroll women in the clubs? How did we share the opportunities? And was there more interest in the clubs than we could accommodate? For example, were there more women that wanted to enroll but they weren't able to be a part of a club?
So In Uganda, where we were really doing a very small feasibility study, women were allowed, in both cases, women were allowed to opt in, although in Kenya we were trying to shift more to having all women be part of the group ANC. In Uganda, where we had only trained 2 midwives out of and nurses out of the staff that were in the facility, we did find that demand started increasing and that those 2 were insufficient. And we had, if we continued on, we would have had to train more staff in the health facility to be able to do it. In Kenya, the demand over time, more and more women did enroll, and the way that women were enrolled into the groups were that during their booking visit, so their first visit to ANC, they were offered the possibility of joining a pregnancy club or not. If they agreed to join, then they would be given an appointment card and assigned to a group based on gestational age.
Great. Thanks, Kate. I just also want to highlight that running up to the webinar, we did receive a comment from the Group ANC Collaborative, the Preterm Birth Initiative out of UCSF, that they are actually currently collecting data on the largest trial on Group ANC to date, and they expect the results to come out in the fall of 2019. And what they've seen so far with their qualitative data is that both women and providers like the group care and feel it was better quality, but again, the providers were experiencing some strain if the centers didn't adequately organize around these group models. So did they do things like ensuring coverage of other services during these group sessions was really important. They shared a link with the qualitative paper, which we will share to the participants of this webinar so that you can also read that yourself. Some other questions that we received was around the setting. Was this study in rural or in urban areas?
I can take that one. In Uganda, as we mentioned, we implemented the feasibility study in 2 districts. Mbale was a peri-urban site, and Bududa was rural. And in Kenya, we implemented the pilot study in 1 county in western Kenya. We implemented we conducted the research across a number of levels of facility, level 5 general hospital, level 4 county hospital, and 3 level 3 facilities. So the level 5 was in a peri-urban area, and then the level 4 and level 3 were in more rural areas.
And in those areas, a follow-up question to that was about male participation. Did men participate in any of these activities?
So as part of the design of the pregnancy clubs in Kenya, we did have sessions where members could invite their partners or husbands to come and participate. So there were certain topics that there were specifically geared for them to be involved in, I believe session 4 and session 6 that focus on family planning and birth preparedness. What we found was many men did not actually come and participate in the pregnancy club sessions. Usually there was usually one partner who actually came at that specific session. So that's something we're trying to also understand is how do we adjust or modify our approach to involving men in antenatal care through these models of pregnancy clubs. It looked like from our experience that just inviting them to a specific session is perhaps not the best strategy to involve men in antenatal care. There might be other strategies. For example, we've heard from some of the sites they took a different approach. Rather than involving men, they invited birth companions to attend these sessions, which could include male partners or other family members. So it'd be interesting to look at how we evolve the strategy moving forward.
Great, thank you. And there was a question, a follow-up question, wondering, do we know the cost of this intervention? Have we done a costing study, or is there a plan to do a costing study?
So we have not done that yet, but we have designed one, and we are determining whether we'll be able to do that in Guatemala. As you may know, MSH has done a lot of costing tools, and hopefully we can apply that approach in Guatemala.
Great. And I think we have time for just maybe one more question. There was a question here about the retention rate and how many women attended more than 3 pregnancy clubs. Shafia, did you want to talk to that one?
Sure. I think what we had specified in our slide, we essentially tracked women who were enrolled in the pregnancy clubs. So they were, as Kate mentioned, they were recruited when they first appeared for their initial booking visit for ANC. They were, as mentioned, had opted in. So they specifically were offered to be enrolled in these clubs and were given a date and time for their first scheduled group visit. We tracked their participation over the course of the 8 visits to understand patterns of retention. We also tracked whether they came for their scheduled group visit, as well as if they came on another date or time for an individual visit. So what we have seen in terms of the standard indicator that's recorded and monitored through the DHS is 4 or more visits, and which is aligned with the former WHO recommendations for focused antenatal care. In comparison, what the DHS for Western Kenya for that 4 or more ANC visits, it's 51%, the average for the county. What we found in our sample is that 76% of the women in our sample completed at least 4 or more ANC visits, and that's a combination of group or individual. So we see there's an improvement over what the DHS reports in 2014, but recognize that there are some challenges related to comparing those 2 numbers. And as mentioned during the presentation, the implementation period was short, so that we really couldn't see the full effect of the model on ANC retention.
So we have a number of questions that keep coming in. I'm going to try to squeeze one more question in before we close the session. And this question is around what kind of spaces were used for the group sessions? Did facilities use existing space, or did they create new space? And did we have to make any adjustments for climate and weather-related challenges to space? Kate, do you want to take that one?
Sure. So this was a challenge in a number of sites because the facilities just didn't have the additional space. In some places, there would be an empty room or something that was easily used for the clubs, whereas in others, sometimes there was no room at all. So there's one site in Uganda, for instance, where they had to meet outside. So certainly climate played a role in that setting. It continued to be an issue that came up in the qualitative research, the challenge of finding the space. That problem was also attenuated by the fact that some of the providers were creating groups that were larger than the recommended size. So we had recommended that the groups be between 8 and 10 women to help ensure fostering of solidarity. And some of these groups were as large as 15 that were being created by the providers. Whether that was to be enable them to cope with larger numbers for ease, we don't know the answer to that. But that made things even worse because they might not have had all the materials or space they needed given the larger number.
Great. Thank you very much, Kate. And thank you again to all of our speakers, Shafia, Kate, Priyam, and for everyone that joined this webinar this morning. We greatly appreciate you spending some time with us. And if you would like to be alerted when we have future webinars, you can register for any future announcements on our website, and we'll also be sending a recording around to all the participants of this webinar. And again, we should be hosting another quality of care webinar in the fall, and we hope you will join us then. Thank you once again, everyone, for joining, and have a great rest of your day.